Okay, I think we'll get started. Good afternoon, everybody. My name is Lynn Todman. I am Vice President of Health Equity at Spectrum Health Lakeland, located in St. Joseph, Michigan. Welcome to Health Equity in Action. This webinar is part of a multi-year series where we address issues of structural racism and how structural racism shows up in health. And I'm really happy today to host three women in the public health equity space who are going to share with us their thoughts about what health systems should be doing to advance health equity. Our first speaker, well, one of our speakers, and I'm doing this in alphabetical order, is Nikki Britton, who is the health officer of Marion County, which is the county in which Spectrum Health Lakeland is located. Nikki is a longtime advocate of health equity work. She has degrees in biomedical, and you'll have to help me out with this, Nikki, and a public health degree from Yale University. And so you can share more about your background if it's appropriate later, Nikki. We also have Dr. Renee Kennedy, who is the Chief Executive Officer of the Michigan Public Health Institute, which is a nonprofit here in Michigan that's committed to advancing population health through public health innovation and collaboration. And we also have Dr. Aletha Maybank, who is the inaugural Chief Health Equity Officer and Group Vice President at the American Medical Association, which is headquartered in Chicago. Dr. Maybank is a board certified pediatrician, among other things. So thank you for joining us in this conversation about what health systems should be doing to advance health equity. As you know, roughly a year ago, many health systems made very vocal and strong proclamations to their commitment to health equity. Many organizations across the country. A year out, some are doing better than others. And the kind of consistent question in this space is what health systems should be doing to advance health equity. And that's what we're going to dig into in a little bit in the next hour. The first question I'd like to direct to Dr. Maybank. She said something in a webinar that was very striking a few weeks ago, and I find is really important information to level set this conversation. And so I heard you recently state that valuing people equally requires that we treat them equitably. Can you explain what you mean by that and why that distinction is important? Dr. Maybank.
Thanks, and thanks, Lynn, for inviting me to be on this panel, and good to be in conversation with the others as well. So, you know, in this work of equity, I think sometimes what's really not clear is that, you know, equity is definitely an outcome, right? We're looking towards a goal of where, you know, everyone has the opportunities, the power, and the resources and conditions to achieve optimal health, right? But equity is also a strategy. And it's very important that we're embedding equity in the process. And then equity is also a value. And I feel a lot of what drives our actions in meaningful ways and in ways that get us to the point of equity have to be rooted in equity. And so I think there is, you know, the knowledge that we all are equal, right? We all are equal when we're born, and we need to value people in that way. But what's critical to an equity strategy is understanding that we all do not have equal resources, conditions, powers, and resources and opportunities just based on the historical context of this country and how communities have been either disinvested, there's been a lack of investment in neighborhoods and communities that have really created tremendous kind of divide in what we have and what the haves and have-nots, sorry. And the reality is that we can't just provide equal resources, but we have to provide resources based on need and be able to redistribute resources based on need. And so that's more so the treat equitably part of it. Recognizing that one, yes, we all should be valued equally. We all are equal in terms of how we are born. In our position, I think just in kind of the earth and being here, but we all have not been treated that way. And so for that reason, we need to have and provide resources in different ways. And we need to understand, I think in that context, just to add real quickly, is the historical piece of it, that where communities are right now didn't just happen, but that there has been a history that has brought them there. And we have to consider that as well in our equity strategy.
Thank you for raising that issue of history, because in a couple of weeks, we're actually going to be unpacking as best we can in a 3-panel series, the historical context for what we see today, the laws and policies and practices over the last couple hundred years and how they created the conditions that we're trying to deal with today. So I'd also like to ask the next questions, getting right to the point. And this, I'd like to direct this to Dr. Kennedy first. What do you think healthcare systems, hospital systems should be doing to advance health equity?
You know, this morning, that question, or this afternoon, I guess we are, strikes me as I would say an ally of healthcare, but not a member of healthcare. And so this question of what should they be doing strikes me in a really interesting way through an equity lens, right? So how can my viewpoint as a recipient and as an ally of healthcare, how can I share some impressions about directions that they can consider, right? But ultimately, one colleague says, no decisions about us without us. They're the decision makers. Healthcare is the decision maker, and we're the partners in that. So I just wanted to sort of clarify that a little bit. You know, one of the things I think is that health systems have to open their eyes to the power that they wield, not just in terms of their 4 walls, right? I have a health systems colleague, and I was saying to her, I'm trying to get my team at the health department to think outside of the box. And she says, well, I'm trying to get my team to think outside of the bed. That's all they think about is at the bedside, what's happening at the bedside. And so I would sort of extend that challenge to health systems, that they begin to think outside of the bed, that where, you know, they all have master plans, where you're setting your ambulatory sites, where you're putting up physical structures impacts the well-being of communities, to the good and maybe to the bad. So always thinking about what is our responsibility to others, not just the ones that come in through our doors, but as a resource, as an employer, as an advocate, as a partner for so many entities. So I think getting health systems to stop thinking so insularly and begin to see themselves as a vital member of a community.
Thank you. Thank you. And thank you for that level set as well. Nikki, can you respond to that question? What do you think health systems should be doing to advance this agenda?
Well, I mean, just to build on what Renee was saying, as the health system is starting to look beyond the bed and beyond its 4 walls and going out into the community and understanding the impact, good and bad, that is happening, and thinking of themselves broader as that resource, as the employer, as the advocate, in addition to the explicit healthcare role, I think it's really important for the health systems to really take a close look at who's already doing health equity work in their community. I would venture to say there is health equity work, even if it doesn't call itself or identify as health equity work, there is health equity work going on in the communities served by nearly every health system. So I would really encourage health systems to be looking at that landscape, and instead of coming in as the institution that maybe has a lot of resources and trying to just take over and say, this idea is new to us, therefore it must be new to our community, to not make that assumption, figure out what that landscape is and figure out how to be an ally in that work. And an ally is really somebody who picks up the agenda of somebody else and uses their power and resources and skills and all of those things to advance that agenda. It's about figuring out what is that agenda in the community, who is already working to advance it, and how can a health system bring resources and power to bear to advance that, instead of now saying, this is what we're going to do and we're going to charge, full steam ahead, sometimes like that bull in the china shop, breaking all the things along the way, but really to understand that ecosystem they wish to enter in their community.
That's really an interesting observation because, Renee talked about the power that's inherent in health systems. And you basically said that healthcare systems need to relinquish some of that power and to kind of buy into the agenda of people already doing the work in the health equity space and communities. And somebody who sits at the nexus of that can say that it is a bit of a challenge for health systems to relinquish some of that power.
Can I also add to that?
Sure, absolutely.
I think also important is that community doesn't only live outside of the hospital, and that's the challenge with the word community itself, right? And when I'm saying it right now, I'm clear that there's a community inside the hospital, but I'm even speaking of those folks who live and are served by the hospital, oftentimes are also working in the hospitals.
Yeah.
And I think if we want to consider equity, we have to look inside of our institutions and how does inequity show up inside the healthcare institution itself. I'm a full believer that we can't do equity on the outside if we haven't even challenged our own ways of being, our practices, our culture within the institution. And so there's a way to even center voices that are most marginalized within our organizations to help support finding out where gaps are and finding out where strengths are.
Yeah.
I don't think we do that enough internally and really prioritize and center those voices. And I will say, it's a push for us at the AMA, but what we have done, we've added, another value in our values, and equity is that, and we have defined it as centering the voices of those most marginalized within the organization. And so that means that you have to find processes and kind of infrastructure to make sure that that is done in a sustainable way. And I think those opportunities are there. And then that group needs to have connection to leadership in very direct ways. So that one, the voices that we're centering and integrating don't feel as if they're being tokenized, number one, and that their voices really aren't valued and it's just an exercise to do an exercise, but they're actually in a space to hold accountability to leadership and ideas. And it's a mutual, it's a shared kind of existence, as was mentioned before, I think, as you were saying, Lynn, like it's sharing power in another kind of way. And so I just feel we have to be really intentional. We can't forget that inside aspect of doing this work.
I just want to add an amen
Sure.
to that because I feel like Aletha pulled that right out of my brain. And I would add having access to leadership and being on leadership. What does you, because, a lot of times you'll see organizations that are, celebrating, we have 52% staff of color. But then you look at where the staff of color fall in the organization, and they're doing some of the lowest paid, least responsible roles in the organization. So splitting, the details, pulling back that onion and really being true to themselves.
And just to take that a step further, because so many members of the community served are employees, they can become the best advocate for the organization and really communicate to their friends and neighbors, yes, trust me, here's what's going on in this organization, or no, you don't want to know what's going on. And so having that buy-in internally is incredibly important. That employees and how they're feeling and how they're treated and the level of responsibility and voice they have certainly becomes known to the community and to the partners.
And let's be clear, it's not easy, right? It's all is very, I don't think any of us are sitting here saying, oh yes, it's an easy thing to do and you should absolutely do it and you should know how to do it. No, it's very disruptive to how most institutions are normalized, where there's a hierarchy and the hierarchy tells folks, how they should, what they should say, how they should be, how they should show up. And I think it really pushes against white dominant kind of culture and supremacy on how institutions have been normalized. So, I put that out there to say to kind of, I think, wrap a blanket around people in a sense that, we get that it's not easy, but it is the right step forward. And I think this is where it becomes helpful to work in partnership with others inside the organization. So allyship was mentioned, the voices, and work as a collective to think through how best to do it. And then also the institution has to be very intentional about providing supports that offer psychological safety during these times, because it is disruptive. Folks are being challenged to change their mental models and how they typically go about things. It causes trauma potentially in folks, and maybe new trauma in folks, and re-traumatizing folks. So we have to be very conscious about that, I think, in the work that we do in terms of advancing equity internally within an institution and externally, and be very conscious of any further trauma that may happen.
So recognizing that it's really hard, and appreciating that there might not be any great examples out there. Aletha and Renee, with your panoramic view, Aletha, your panoramic view across the nation, Renee, your panoramic view across Michigan, are there any models that are beginning to show shoots in that space of, kind of redistributing voice throughout the organization? Or are we still in our infancy stages on that as an industry?
Renee, I'll let you go first.
Well,
That's a tough one.
I know, right? It is a tough one. I'll just talk about my own home for a second as an example. I mean, when I came to MPHI, we were a predominantly white organization that had been founded by and led by a wonderful white man, but a white man that, this just was not a part of our vernacular, of our culture. I mean, we were good people, we were servant leaders, we were doing wonderful work, but nobody thought about the lens, sort of the racialized lived experiences. And what I learned very early was that I had this oddly revolving door for staff of color. Like, they'd go online, they'd see, wow, there's a Black woman leading this organization. They'd apply, they'd get hired. And about a year later, they were just heading out. So for us to then begin to do what's being referred to as deep equity work, to really look at ourselves, look at our values, have those tough conversations with my leaders, because we're broken up into centers. And if I'm doing it in administration, but it's not trickling down to various other centers. And so we began doing that hard work. We now have a Center for Health Equity Practice. We now have a Center for Culturally Responsive Evaluation and Engagement. We now have 28% of our staff as staff of color. And so these are the efforts that over 7 years, we were able to actually do some very deep work. And because we did the inside work, our portfolio of work begins to look very differently. And I think we see similar things. I mean, our state health department is a super agency, which means it's a health department and the Department of Health and Human Services, about 14,000 employees. But that leadership has begun doing some of that heavy work before COVID came on the scene. We were talking about maternal mortality and infant mortality, and really looking at the racialized experiences of women and children during pregnancy. And so, my chief financial officer taught me this concept of tone at the top, which is what tone, what culture is that senior leader establishing. And I feel like we have that at the state of Michigan. We were easily able to flip to a COVID task force on racial disparities because we had begun that conversation around Black moms and babies. And so when we said to the governor, this is a problem in COVID, she was already poised to act with us.
Go ahead, sorry.
Go ahead, Aletha.
Okay, great. So that Renee's comments caused several thoughts to come to my head. One of them is the difference between healthcare and public health, and from being in both and spending most of my time in public health and now being more rooted in healthcare. I think public health as an area is probably a little further ahead in terms of more critically thinking about and having action towards advancing equity, and what does that mean at the institutional level. I'm not saying it's optimal. However, I am saying it is, I think, ahead of healthcare. I know it is ahead of healthcare. And so, I think Renee, is one of the folks when I was in public health, definitely always looked to her and the leadership that she was providing in Michigan. I also think places like Seattle, King County, and, have been doing this work in terms of the institutional in order to kind of inform and impact the community level for plenty of years, and is a very good model. On the healthcare side, I think there are budding examples. You have Mass General and Brigham's that are, they're really they've started over the last years, really explicitly talking about racial equity, using the language, setting up the systems and the internal trauma supports needed in the organization as well. And I think there are other networks such as the Healthcare Anchor Mission Network that is convened by the Democracy Collaborative, in which healthcare institutions are more intentionally thinking about how to take their resources and apply them upstream at the neighborhood level, and then also thinking through racial equity. I think where the next frontier in all of that is also how are we bringing healthcare and public health better together. So I think Renee just elevated an example of that at the state level, when you have kind of health department merge with Health and Human Services and the opportunity there. But then how do you also bring kind of healthcare into that? And so in the west side of Chicago, they have an effort called West Side United. It's actually one of the first times that AMA has done something really in their own backyard in terms of actual investing of dollars. And so this is a community-driven effort, probably about 5 years old now. And really, again, community-driven, but it also has 6 healthcare anchor institutions, as well as the AMA, that have put investments in financial, $2 million into the West Side United community. And the health department is a partner in that. And the mayor's office is a partner in that. And so what happened, because that infrastructure is there, it's like that infrastructure becomes an emergency preparedness almost opportunity. And so when COVID came around, similar to what Renee mentioned, they were able to kind of transition to becoming racial equity rapid response teams for the West Side United, as well as for the South Side, because that organization was already there. There was already the prioritization and value of community voices being integrated and leading it, and then also the prioritization of equity and racial equity more specifically. So those are, I think, there's a movement there. We just need more, and honestly, you just need more resources and funding into these types of opportunities and these collaborative and collective opportunities.
Yeah, it's hard work. Nikki, I want to ask you this question. Both Aletha and Renee alluded to this, the partnership between public health and healthcare. Can you talk about what your experience, in that space has been, what has worked, and how other healthcare systems and public health departments might think about collaborating in this health equity space?
Yeah, and I think it's really important. And I think in a lot of communities, it's an undertapped potential there in that relationship between the local health department and the health system. Our experience here in Berrien County, working with Spectrum Health Lakeland, has been really good, but it's also been, a decade in the making almost. So Spectrum Health Lakeland does have a population health department and has had some of that foresight and has been a little bit ahead of the curve in trying to have a team that is thinking outside the walls of the health system. But our health department has worked very closely with that population health team, and we've really sought to have some authentic partnership and alignment there on that issue. And really starting to view ourselves as one team that is serving the community, but we have 2 different organizations that we work within, but not rigidly, but we have adopted a little bit of a collective impact model to where we have aligned ourselves to go in one direction. We're trying to set some common goals that are mutually beneficial to our organizations, but ultimately are most beneficial to our community residents in advancing some of those health outcomes. COVID has given so many opportunities for us to really work together when, information was the key public health intervention at the beginning of the pandemic, making sure people understood what was coming, what was needed, how to protect themselves. And so we were able to take some of the strengths that the health department has and knowing the information, being able to package some things, but then we were also to work with the population health team, your team, Lynn, to really leverage some existing relationships and build upon trust that are already happened. So with some of the connections we as the health department had, some of the connections your team had, we were able to really elevate that work higher up and engage some informal community leaders to get information out to the community. And we did it in a way that it didn't have our logo, it didn't have your logo. It was just for the sake of information and for the sake of advancing health. That's where there's a little bit of that power give. It's okay that we're not getting the front and center credit for it. We want people to be healthier. And I do think that lives were impacted by that action. As we were turning to testing, there's collaboration in where the testing sites need to be. What are you seeing on the ground? How can your team do this? As we've rolled into vaccination, it's been a similar sort of thing. Our department has been really busy and consumed with actually administering some of the vaccines, but your team has had some bandwidth to be able to do more community dialogue, really do some of the listening, address some of the questions, bring those back. Neither one of our teams has enough bandwidth, but together we've been able to increase our reach and the fact that we're in that relationship. So I think really connecting the community and population health part of the health system with the local health department in a way that those staff members even see themselves as a united team is just really important. I think our work has reached new levels at a point when members of my team that don't even report to me, that they're really deep in our organization, are then emailing and calling members of your team and bouncing ideas off each other and really coming up and activating new ideas or taking things to the nth degree, just taking them a lot further. So that I think has been really, really beneficial and has allowed both of us to respond to what each of us is hearing.
Thank you. Thank you.
I really want to underscore how vital that relationship is. And I'm going to use a pre-COVID example, but when I was health officer at Ingham County, as Nikki is, I was responsible for the childhood immunization rates in my county.
Mm-hmm.
I got to get the data. I got to report it. If it's looking bad, I got to give an explanation. But I'm not responsible for giving all the vaccines
Right.
to children. I couldn't do that in my clinic. And so it always amazed me that there were so many jurisdictions where health systems were not in relationship with their local health department. And so COVID has clearly helped us see the importance of that. But in some of the worst case scenarios, health systems are just out there giving vaccines without being a part of a coordinated process where we can look at where's the greatest need, where are the potential inequities, where are access problems. And so I would really underscore the importance of health systems to initiate a relationship. If they don't know who their local health officer is, they really should find out. Take them out to lunch when we're able to take someone out to lunch again. But that's just, to me, it's almost absurd that we don't have deep and abiding relationships between local public health departments and health systems. Because if children are not getting vaccinated, children are going to get sick. Then they're going to be at your doorstep. They're going to be at the health system's doorstep. So preventing disease, partnering together for well-being is vital.
I'm gonna just do a shameless plug for our organization because Nikki actually sits on our board. That's how close the relationship is.
Right. But that's been intentional action. And
Yeah.
It wasn't just me. My predecessor was also. So that is something that the board and the senior leadership at Lakeland has taken seriously for a long time. And we've taken steps to be intentional. We would have never done the things that we've done with COVID if we didn't have years and years of practice working together ahead of time. And I think that's where we're starting to see some of the cracks right now. In other communities.
It's almost like so there are the strategies for equity, but I feel part of the strategy for getting to equity is ensuring that we have better coordination between healthcare and public health. And I think folks need strategies on being able to do that, and ideas and suggestions on how to do that, because it's not intuitive. I think it's more intuitive for public health than it is for healthcare, just because of the nature of one, how you're trained as a healthcare professional. It often just, as you said, it's about the bed and around the bed, right? And in the halls of the hospital and the doctor's offices. So that natural context and I think curiosity just isn't really always there on the healthcare sector side. And it stems from leadership all the way down to the trainees of med students. And so there's an opportunity within healthcare systems and institutions to kind of to train more, I think, and to provide more education for the med students and residents that are in the system, because they're going to be the leaders clearly of the future. And if we can get to them and start modeling them with them and sharing with them, allowing them to make these connections and to show them the importance of these connections, maybe we start to have a healthcare system that has leadership that then begins to value that, or even attendings, when they become attendings, they value that. But I see that as a huge gap, being in the space that it's just not part of like the energy of folks to naturally to go that way. And we have to kind of really push people in that direction.
Yeah, it's critical to the equity agenda that the two work closely together. I'm going to pivot the conversation a little bit and ask about national and state policy landscape. The biggest news is, the rescue package that has come out, but I wonder if you have any thoughts about how healthcare systems might leverage their power, Renee, to shape, inform, or somehow leverage the policy landscape for the benefit of health equity. What should health systems be doing? Because typically my understanding is the advocacy around in health systems is really just in the healthcare space, right? So I just want your thoughts on, Renee, you can start your thoughts on that.
Well, I have the privilege of serving on the board of directors for a health system as well. And I'm pretty sure most health systems have a government affairs relations / lobbyist person that comes in, gives a report to the board, does their wonderful work, runs up to, in Michigan, it would be Lansing, to the Capitol. And I think that, again, what is the lens that government affairs person is bringing? Are they understanding not just their responsibility of the health systems, but the context? Are they understanding issues of equity? They are drivers of very important dialogue. And we always say that facilitated dialogue is a way of doing. It is an action. We don't want to just sit back and have, light conversations. We want deep and advancing dialogue to affect change. And so what is the lens and the understanding that those folk, oftentimes who are attorneys, are bringing to that frame? And we have wonderful examples of attorneys that do deep equity work. Beverly Crenshaw and her intersectionality work was done from her training as an attorney. And so I think that that's really important, because oftentimes there are policy decisions that are made that have unanticipated negative consequences, for lack of a better term. And so when things are trickling down from the federal to the state and from the state to the local, if there are negative consequences, particularly to unique people groups or communities or whatever identity frame we're bringing to that, who then has the voice to run that back up the flagpole? This was good, but this problem occurred, or this happened and this happened. So I think that health systems could really be great advocates in that space beyond, what your reimbursement rate. I mean, we do know that money does make the world go round or whatnot, but sometimes things that are of social good are not necessarily profitable. And everything that's profitable is not always of social good. I remember reading this in a story from Forbes on why public health should not be treated as a business. We sometimes make choices and decisions because it is the right thing to do. And I think that is the space where health systems and the power of their ability to advocate and lobby and meet with legislators is really important.
Advocate and lobby. Letha, do you have any contributions to that question? I'm sure you do.
Yeah, I mean, and that's about it. Advocate and lobby. I think there are a couple, again, challenges and opportunities as I see now being in this healthcare space. You know, there's a narrative that's out there that healthcare or physicians, let me be more specific, that physicians and healthcare workers should be apolitical, and shouldn't be bringing that context. And I think it's a false narrative. I think it's a very confusing narrative, and I think it's an inaccurate narrative on many levels, because I don't think that that's how healthcare and the power in healthcare operates. I think the power in healthcare, because it does have money, it does have a very strong political voice and an advocacy voice, whether it's at the federal level or the local levels. I know that from being in the AMA, now, and the reality is like our strongest, our greatest strength is the amount of advocacy that we do at the federal level. We are very engaged in politics, very much understand politics, but there's been this narrative that's been put towards, the rest of the folks in healthcare that they shouldn't be here. And that's just not, it's not even fair. And it's not true. And I think what I've found really, I think, energizing during this time of COVID is to see the number of healthcare providers that are now engaged in advocacy and politics and interested in, whether it's via social media and they're tweeting and they're talking about it, or they're actually doing petitions and engaging and sending letters. I think it's a new wave of being. We just launched a fellowship actually called Medical Justice and Advocacy Fellowship. I didn't remember what the title was. And this is specifically focused on fellowships for physicians, for them to understand better the root causes of why these inequities exist, but to understand better the political determinants of health, so that they can become leaders within their local communities or the national community, wherever they choose, to be providing voices, but also to be working collectively with others, whether it's in public health or social services or wherever it is, to think about how to advocate more so around the root causes and the public health aspects, really, of why health inequities exist. And so I feel that we're now, COVID has provided a lot of opportunity as well, I think in the space of equity that we just need to fully capitalize on. And I think the other opportunity that presents itself in terms of the policy landscape relates to the new administration and some of the executive orders that have been put forward as it relates to equity across the administration and racial equity explicitly. And I will see how that plays out, and if there will be some depth and sustainability to figuring out how to apply this across all federal agencies. But I think there's a tremendous opportunity there if done well.
I think there are sort of four phrases that get in the way of progress in my mind in this space. The first two are equality and equity. And Aletha did a wonderful example in your first question, that these are not the same things. But I see similar confusion around politics and partisanship.
Yep.
And these are not the same thing. COVID doesn't care whether you are in the red party or the blue party or the green party. And those are not the same thing. And so the more we can push back against, oh, we can't talk about that because that's political. No, you can't talk about it in a partisan way. You're not trying to tell people how to vote, but you are trying to equitably educate people about the politics, the decisions around scarce resources, the decisions amongst priorities of choice. Politics is vitally important in healthcare and in public health.
Right. And I guess just to add a little bit or reframe some of what you all have already said, so often people equate health with health care, and that the quality of our healthcare equals the quality of our health. And if there's something wrong with the community's health, that's either reflective of the healthcare system or their access to healthcare. And while healthcare is certainly part of that, one of the things that in public health we're continuing to say on repeat, but we don't have enough loud enough voices and enough power in that situation sometimes, is health is so much more than healthcare. And there's really only so many things that healthcare systems can do for primary prevention. Healthcare will not prevent something from happening most situations. It will notice something early. It will help protect the longevity of your years or prevent a further illness or death from something once it's in place. But there's a lot of that primary prevention, preventing something from happening in the first place, that happens in the community. And when those issues are happening in a community, it's a reflection of the housing system. It's a reflection of the education system. It's a reflection of the transportation system, of the wages in that community and the employment opportunities and all of those things. And so if as healthcare is leaning more into advocacy and understanding the policies that underlie health or that are beneath a community's health and at those root causes, that can help shift the entire community's narrative around what makes health. Because really, to solve some of these really complicated and very historically rooted health inequities that we have to understand what the problem is. And as a community, as a society, we haven't quite determined what the problem is, or we haven't come to consensus on what the problem is. There's lots of evidence out there that fully underlies that. But I mean, to borrow from healthcare, the diagnosis determines the treatment. So if healthcare systems can help broaden the narrative of how health is made, how health is maintained, how health issues are prevented, that can make more space and a better understanding amongst other types of decision makers, including our elected officials, to understand how all policy really is health policy, and all of those actions really do that. So I think we need the power of health systems to help shape that narrative and refine that narrative and make it clearer in our communities what we need to do to improve health.
I wholeheartedly agree. Yes, that is it right there.
I think the question is, how do we get boards comfortable with that paradigm shift?
Mm-hmm.
Like making the distinction between partisanship, like how'd you put it, partisanship in politics, and really using the heft of, their networks, their, financial and other resources to actually influence some of these decisions outside of healthcare that actually impact the healthcare industry. So I think that's part of the challenge.
I would encourage boards of health systems to get steeped in the community. Yeah. Maybe bring patients in to talk about some of their lived experiences. I mean, you can't listen to the atrocities that people have to manage just to live without having a check in your heart. And we always say this is head work and it's heart work. So if boards will allow themselves to get into their heart as well as their head, then you start driving. It's like, how dare I be uncomfortable having this conversation when this young woman with her 2 children is living in discomfort every day, and I'm sitting back not doing anything. And so just getting to what we call in one of our grants, productive outrage. We were trying to create health system leaders to land at a place of productive outrage where they start doing something.
Yeah, I really like that. And I think now, again, being more and more in this space, coming from public health, coming from leadership, like Dr. Bassett and many of the folks that I was around, the heart was there, it still was a struggle, but the heart was there. Now coming into more of a corporate type space, and hearing from folks who want to tell me, oh, you need to present the business case. You need to present the business case. And I'm like, I've watched people, over the last year, and I've watched what has literally moved their faces, and what conversations move their faces. And the reality is that numbers are important. We understand this data are important, but they don't move hearts. They just don't do that. They I think reinforce, again, structures and norms and decisions and how they've always been made. But you start to tell the stories, we're going through a moment right now at the AMA. It's the stories of our employees and their experience is right now, as well as our members, I think is what's really moving leadership to really sit with what injustice looks like and what injustice feels like, and how decisions institutions can make actually can cause trauma, not just on a one-time basis, but on a repeated basis. And it's those stories of hearing from the staff and from others that I have seen people, white men, come to tears in listening. And there could be many reasons why they're doing that. But the reality is it has moved them in a different kind of way. And I think that that is absolutely critical. And it's not only for our patients to come to us as boards or to the boards, but for us to be willing to go into our communities and to sit with people and to hear about it, experiences. And this is not to be, this is one caveat to all of this, because I'm very conscious and more so conscious that this should not be at the burden of people of color and marginalized communities. People should be willing to share and want to share. They should not have to share. This is not something they have to do or must do. The work of dismantling one's own context and biases and how they show up in these systems of racism and white supremacy is work of one's own self. And we are blessed if we have the opportunity to help people along with us on that journey. But I think it's in a very important frame. It's not other people's responsibility for us to undo our own and dismantle our own spaces of racism.
Thank you. And, we only have about 12 minutes left. I wanted to engage you in conversation about, our senior leaderships, because there's the board, there's senior leadership. I won't go there, but if you decide you want to take that on in the course of the next couple of minutes, you can. But I do want to ask you as we close out, what gives you pause in these times? So there's a lot of optimism that things can actually change. I was talking to, frankly, my husband not too long ago, and we decided that it was the 1960s when there was a watershed moment, like what we've seen in the last year. And, while a lot has changed in that 60-year period, a lot hasn't. So what gives you pause in these otherwise optimistic moments for health equity work? So anyone could start. Anyone?
Well, today, I don't know that I would say it's otherwise optimistic. Catch me tomorrow, maybe I'll be in a better place. But what has given me pause is just the frustration of the recurring, predictable pattern. When we look at these lives lost last week from our Asian Pacific Islander brothers, the exact same pattern. It's the same thing that our Arab American brothers and sisters experienced after 9/11. I mean, this whole, the deeply rooted belief, as Dr. Gail Christopher says, in a hierarchy of human value, it just is steeped. And maybe it's because I'm watching this documentary called Amend on the 14th Amendment on Netflix. You're in quarantine and you're just watching way too much TV. But it gives me pause to just say, if we don't, it's going to take something revolutionary, if I could use that term, to break those mental models. Aletha used that term earlier. These are deeply held beliefs that keep doing the same thing, or they play out exactly the same. And I feel like this enemy that we battle has a teeny tiny bag of tricks, and they just keep plummeting the same one at us, and we keep falling for it as a people of humankind. So that gives me pause. That what is the disruptive thing that we can leverage to get us in the right direction?
Well, hold on, because I'm gonna ask you what gives you hope after that. So we'll end on a good note. Aletha or Nikki, anything give you pause in these moments?
Yeah, I mean, just honestly, to continue in that vein, it's just the exhaustion, the sheer exhaustion. I felt for doing this, what, 15 years or so now. I know it's not long, but it's long enough, and in this last couple of months, especially, and this last year, or even these last 2 weeks, um, it's just to the same point. It's like, when does it stop? Like, and it's, and why am I doing this? Like, it's just, and it's tiring and it's exhausting, and we're just up against like a beast. Like, and it's just, I'm not seeing sometimes the way out. Even in light of all the exposure and all of, I think, the opportunity of this year in terms of being able to name racism and explicitly do that. But I think, as Renee's mentioning, the tricks they come out differently. We name racism, and somebody's going to be there to figure out how to quell that excitement, and maneuver in another way, and the resistance will rise, and it is. And so it's just, then you have to figure out, the next direction, and it's very exhausting. I've come to that more so than I've ever have before.
It's interesting coming from a physician, given burnout as a phenomenon, this is more exhausting.
Yeah.
Nikki, do you want to handle that question?
Yeah. So for me, on a different end, I feel like, being a white woman, my work is a little bit different. And so some of the things that give me pause, in addition, that I'm feeling just really concerned about cancel culture, and the fact that we have been, as a culture, feel like we're moving into a place where we are challenging people more than we're challenging ideas and more than we're challenging thoughts. So I think there absolutely are patterns of thinking, ways of behaving, ways of carving out institutions, like all of that. There is very deplorable, destructive stuff that needs to be 100% called out. But when a person gets just carried off into the sunset, as in they are no longer redeemable at all because of how they've participated or perpetuated some of those things, it makes the work less of an invitation for others who have the power to make change. And so it's a delicate balance there of, we don't want to just say, oh, it's okay, because people are dying and this is life or death stakes. At the same time, I really believe that this work is an invitation to really restore our own humanity. And it's a place to find what makes each of us human. And we find that and dig deeper into that as we do racial equity work. And I just can't reconcile this notion of somebody gets cast off forever, never to be able to be part of this work. And in some ways that can lend towards some extremism that is not helpful, because it's not an open invitation. And there's tension in that. And I know that that might not be something that everybody agrees with, but that is something that I've been really trying to work to reconcile.
Thank you. So in our last moments, listen on something positive. What gives you hope? What gives you, see, I already got smiles just asking the question. So anyone who wants to go, what gives you hope in this moment?
Well, I'll consider myself the elder stateswoman amongst these two dear colleagues of mine. And Aletha commented that she's been in the game for 15 years. I've been in it for over 30. What gives me hope is that when Aletha is at the 30 plus year of her career and Nikki is at the 30 plus year of her career, that they will be able to list and articulate numerous accomplishments. I mean, we are not as far as we need to go, but we're certainly farther than when I started my journey. I mean, there was a time I was beating my head against the wall just trying to get somebody to say diversity. And so we have made, we've made progress. This is, I think, what gives me peace is that this is generational work. And we are not the generation that's being sprayed by fire hoses and attacked by police dogs. but we are the generation that has to choose to not be weary in doing the right thing. Don't be weary in well doing, one of my favorite quotes says. So we have to choose, to get up every day and take it on one more time, because generations are depending on us. And I'm generally an incrementalist by nature. I think small bites will be lasting bites. But I have this new reflection. I was home and with my great grand nephew, who's a toddler. And man, he was scurrying across the room. He had just started walking. He was like flying. And all of a sudden I was like, baby steps. But man, babies can move really, really fast. So baby steps and incrementalism is okay. But I'm confident. I'm confident that we are on the road to progress. And so encouraging each other and not throwing in the towel is what gives me hope.
I love that perspective, Renee. I love that perspective. Aletha, Nikki, what gives you hope?
I would say, the young folks, the med students that I interact with, their energy, their excitement, their clarity in terms of analysis, their clarity in terms of what to advocate for. I get that poses challenges and does butt heads against generations, the 60s generations, as they'll say. And they come, they don't believe in respectability as much and all of that. However, I feel, I don't know, the energy and the drive and their excitement really gives, for me, especially at the AMA and interacting with students, it gives me the excitement to do this work. They're the ones who've led the work in our anti-racism policies and putting them forward and getting AMA to pass them, our transgender, equity policies. So they're there. Not all, I'm sure not all young people, but they are there in terms of wanting to advance equity in very direct and meaningful ways. So that gives me hope. And I agree with Renee in terms of on 2 points, the sprint and the marathon of this. I usually roll my eyes inside when people say this is a marathon. I'm like, okay, but when these doors are open, we need to sprint through them, because the doors close. So I think it's both. And then also to the point of, I am very clear that I'm here because of all the people who came before me, from the times when colonizers landed on this land and committed genocide upon the people who were there, stole the land, and then forced, folks to this land. I am standing on the shoulders of all that sacrifice and really hard labor. So I'm very blessed and grateful for that legacy, and just want to make sure I continue it forward.
Thank you. Nikki, what gives you hope?
I just think that there's so many people, so many more people in the last couple of years have wanted to enter into this dialogue and are desiring to grow and then take action. And just seeing that I feel like we're starting to reach a critical mass where more and more people are understanding. They have a structural lens, they have a good analysis, are able to understand some of these things, underlying health inequities and racial inequities. I think we're building that critical mass of people who understand that can really help make change.
Great, great. Well, we're just about at close. Before I thank all of you, I do want to talk about, because each of you touched in one way or another on this issue of the history, the historical origins of what we're facing. And I just want to do a shout out, let you know that our next CGR event is going to take place on April 13th. That's a Tuesday at 7 p.m. And we have 3 historians who are going to talk about kind of, the legislative policy and practice origins of what we're facing today, from slavery to the Civil War, 1600s to 1860s. It's the first of a 3-part series that will end just before Juneteenth. So you can go to the CGR Community Grand Rounds website, find out information and register. Then I'd like to close with, these are 3 incredibly busy women, and I am so honored that each of you took the time to spend time with us today. I am not overstating it when I say that this panel took a year to pull together. So I want to thank you, the three of you. You've given us lots of great food for thought, and I appreciate what you've done, and I owe you one or two. Anyway, thank you. Thank you, everyone, for joining us.
Thank you.
Have a
Thank
nice
you.
afternoon, everyone. Bye-bye.